So next case is, we have a 64-year-old gentleman, a hypertensive smoker who had effort angina with mild LV dysfunction. His angio shows RCA is non-significant disease. LED shows significant 70% ostial. Circ shows osteoproximal 80% and ramus ostial significant with mid-part involvement. Our plan is LMCA bifurcation followed by OCT evaluation.
Dr. Sanjay, you're on.
Yes, okay. We have already cannulated left main with 7 French EBU guiding. We are just taking shoots. Epicaudal. Okay, good yellow caudal. Deep yellow caudal. Yes, this is a good view. It's fine. So again, I think it's a case 40 stenting. We have taken 2 wires, one BMW, one run through.
Yeah. So run through in LAD, BMW in circumflex, right, Sanjay?
So Sanjay, Rajiv here. Do you think the circumflex you need to come all the way back to the origin, or you think there's a landing zone?
Good question, Rajiv. I feel that the LAD ostium has a lot of plaque burden, and that is going to shift. So that's why, you know, myself and Sanjay discussed a lot about this case, but ultimately we thought to consider it as a left main bifurcation. What will you do?
No, I think that's a very important comment. So there's a huge plaque burden there, and I think for the sake of 1 or 2 millimeters in the circumflex, I would plan a 2-stent strategy.
Yeah.
My other question to you is, what's your strategy if that small ramus or first OM gets occluded? Do you say, fine, I'm accepting it, or are you?
I have selective blindness. I don't see that artery.
Very good.
Run through, anywhere is okay. Anywhere, any branch.
We have other panelists on the other side of the room. Maybe your comments would be appreciated, how you would tackle this left main disease.
Thing is, I was maybe an option because I saw some calcium in even the fluoroscopy shows a lot of calcium in the proximal LAD. I was maybe indicated because some plaque modifying thing will be required.
Or you
So that's one thing.
Okay,
and of course, two-stent strategy is the best obvious. Probably I may even go for a simple strategy like a tap. Probably the angle is good enough.
So Tejas, I heard you said you're gonna not do anything to the ramus, right?
Yeah.
Then I think plaque shift is not going to be issue here because it almost looks like a 180 straight line, you know. It's like typical threshold type of thing. So
I want to add one comment. It's the first time I've heard Tejan's first comment not to be to do with a long sheath. And I congratulate him on his restraint. Well done.
I think he is to be shifted from Rochester, New York to Rochester, Minnesota for time being.
no, now with the aging, it's actually not it's not horizontal movement. Now it is vertical movement.
You mean you are old?
No, I'm just less young now.
So Sanjay and Tejas, do you have an algorithm as to when you would use rotational atherectomy? In most cases you use fluoroscopic calcification to make your decision?
So, yeah, it has always remained, you know, there is some enigma, I don't know. But sometimes you see a severe calcium on fluoroscopy. We have a tendency first to put the balloon and try to open up. 10, 11, 12 non-compliant balloon, if it doesn't open up, we just don't worry and we will straight away take rotational atherectomy. But many times, you see terrible calcium and it opens up. Maybe it is adventitious calcium, and sometimes you see hardly any calcium and it just doesn't open up. I wanted your comment. But rotational atherectomy we are using, and we are using to increase our success rate from 99 to 99.9%. Of course we are using it sparingly, but we are using it regularly.
2.5 no?
Yes, I think
2.5 by 12, 15.
I think even in 2018, the unpredictability of the lesion happens. We think sometimes you have to use it and you get away without it, and similarly the other way around. And I wish there was a strategy that told us exactly when it was necessary. I will say that one of the things I think we're learning from the CTO world is that if you do have a limited dissection after balloon angioplasty, it's still okay. You can still proceed with rotational atherectomy. We used to say never do it, and now I think as long as you're careful, use a small burr, that a limited dissection is not a contraindication to atherectomy, at least in my opinion. Maybe colleagues across the aisle there, or Dr. Akasaka with your CTO experience, maybe any comments from you?
No, I think I agree with you. If I do balloon angioplasty and you still have a difficulty advancing bigger balloon or stent, standard of care before they do anything else, definitely 1.25 bar fluid runs, and then it will definitely work. As a matter of fact, had opportunity even in acute MI settings that I had done rotational atherectomy without much issue.
Could I ask Rajiv and Tejas, would you say the same for laser?
Oh, so great comment on laser atherectomy. So I think that, yes, I think I would say the same comment on laser. I mean, it's a different mechanism of atherectomy. Almost would be potentially even safer that there's no mechanical concern about lacerating the dissection. So perhaps laser would be an even better option after balloon angioplasty. Tejas or my colleagues?
Yes, fine.
I have no experience with laser, but what you allude to it actually, it's a mechanical disruption which rotational atherectomy will create further compared to laser, which is not as much an issue because you're tearing that dissection or burning it basically.
So Rajiv, I had cases in which I was completely unsuccessful with laser and was very successful with rotational atherectomy. And laser can also cause significant dissections as well if you're not careful or if you don't advance to 1 millimeter per second as prescribed.
I think it's a very wise word, and it's a reminder that laser used to be a contraindication. I mean, calcification used to be a contraindication to laser, and we've learned more recently that you can aggressively make the laser aggressive by injecting contrast, but there are risks with the laser too. And I think dissection is one, and we have stents for that. But the biggest risk I would be concerned about is the risk of perforation, and that can be unpredictable. I would imagine there's a higher risk with laser compared with rotational.
A lot more successful ablating calcium with rod ablation than laser.
100% agree. Yeah.
But we're talking about laser and atherectomy here. I'm actually just very curious to know how often it's used in this part of the world. And maybe the panelists on the other side, is laser or atherectomy used at your institutions or in your region?
I'm Dr. Sabina Hashim from Bangladesh. I was asking whether it is use of any scoring balloon or in non-availability of the scoring balloon, can we use non-compliant balloons? As there is a calcium seen in the proximal part of the leading.
I think those are very good options when you don't have laser or atherectomy, and certainly some people who don't feel comfortable using rotational atherectomy will try those devices. And actually, most of the time, they're very helpful. But the amount of calcium that we see in many of the patients currently, it seems to be a lot more than we ever saw before. And in some of those cases, I can tell you that unless you've got atherectomy or laser, you're just not going to get through. But I think those are very good options if you don't have that technology available. But so in Bangladesh, is anyone doing rotational atherectomy or laser?
Our center, we don't have rotational, but Professor Dr. Fazila Malik in Heart Foundation, she is doing a rotational.
Hello.
And some of the other centers, they have.
Because it's still expensive technology and not so easy to use.
And I think your point, Malcolm, about the differences in populations. I mean, the mean age of our PCI population is now 71, and the mean age of the patients I'm seeing here is, I don't know, 50 or less. So all of us, so many of our patients are 80, 90, and the extent of calcification is incredible. And maybe it's just the difference in patient population really is reflected by the ages.
Okay. Understand Katapashi.
But that we will leave the normal segment. We will stent the distal mid LAD first, and then we will use two stents.
So Tejas, two stents in the LAD, so one in the LAD and one back into the left main. Is that your plan?
Proximal dissection.
Just show the previous view.
Previous view. What dilate kare? Dissection.
We will have to cover everything.
Yes, because there is a dissection.
Yeah. Just show me the previous one now.
Previous.
No, not this. Forward. Forward. No. Yeah. No. Yes. So we stent this area.
Yes.
And then we will think.
Lamod le liye apne, then so LMCA to LAD will be short.
2.75?
Yes. 2.5.
This is 7 French, which is 2.3. 2.5, 2.75 by?
Okay, by 32, 33?
33? Giants Expedition or Alpine?
No.
Yeah, what were you asking me?
It was just your strategy. I think we're understanding it, listening to your conversation. So you're going to have one stent in the LAD, then you're going to do the left main as a separate entity.
That's right, because in a previous view you can see there's a nasty dissection. It is not seen in this view, in the LAD. So we'll have to overlay. So you can see there.
Here you can see.
Or is it a branch, Sanjay?
No.
Okay.
So we have dilated there.
Okay.
Previous before balloon dilatation it was not there.
Yeah. That's smaller than ramus intermedius artery even.
You are after ramus now.
No, I'm saying that dissection slash small branch is very small, so.
So Tejas and Sanjay, tell us when you choose left radial, do you use the algorithm for access of a short patient or elderly patient, or you still default will be right radial?
It is like, if we have right radial access available,
yes,
we don't choose left radial.
Exactly.
Unless, Rajiv,
little back.
Unless, we are addressing the infradiaphragmatic lesion in a person above the height of 5 feet 10 inch, where if I use the left, and if I puncture high, I am saving 10 centimeter of the length here and 10 centimeter of the arch, and using the regular hardware I can fix the iliacs or whatever below.
Backline up here, high pressure. 12.
What is your algorithm, Rajiv?
Yeah, no, it's a good discussion. So one of the major challenges for right radial intervention in the West is this innominate tortuosity, subclavian tortuosity, which seems to be more of a problem in the elderly, calcified, and we know that the left subclavian is less prone to that. So many people will look at the two randomized trials that compared left and right radial access and say that the elderly, over 75 or short, 5'5" or less, will go left radial. That's certainly my practice, and it's one thing that's changed significantly over the last 5 years. Is I now am about 15% left radial. I used to be hardly ever any left radial. And
but are you comfortable?
No.
You're working from the right.
No, I'm from the left. I mean, my back doesn't thank me for it. In the Midwest in America, our patients are, I would say, 3 times the weight of many of the patients we're seeing today.
You make a habit of puncturing the distal radial on the left.
Yes,
that
yes.
will make your life easy, I suppose. If the arm remains in pronated situation, you can keep it a little further and you can have a straight back and work through the left radial.
So now stand size for T-stand.
So go to epicaudal view or aleocaudal.
Fine.
Okay.
So 23,
Are
sir.
this
3 by
even
23.
LED?
LED is small, shorter.
18.
18.
18. One thing I have a doubt, there is some distal left main.
Yes.
Let us see.
It's tapering.
Tapering.
Yes.
So I want to cover that area.
So 18 will cover.
18 should cover. Rajiv, what do you think? LMCA to LED?
I would ask Sanjay and just do exactly what he says.
He says 18.
Yes, 18. 18 is
Then
okay.
there's no more questions.
So here 3 by 23.
Yes.
And
3 by
here 3.5 by 18.
18. Yes.
Get me Science Group, Expedition or whatever. Yeah.
So, guys, while we got
Previously-
you here, so your standard approach would be PCI in this anatomy, or would you stop and have the patient
Okay,
meet with a
next,
surgeon and
next.
discuss the pros and cons? Maybe you
Good
can offer.
question. Always, the first option given, even in our lab, is CABG. Only when patient has reluctance, then we say that this is a reasonable option and we have adequate experience to deal with it.
Yes, so very, very similar, I think, for other countries. Sam, Maurizio, and Kinter, any comment on that?
There are 23. 23. Hello, sir. Come on.
No, I think, we have the same practice pattern for many reasons.
Tejas, could you tell us how many PCIs are done in your hospital each year? How many CABG surgery done in your
Good
hospital?
question, yeah. Around 1200 PCIs, average 100 PCIs a month, and CABG is average 35 to 40, so around 450 CABGs a year. We have a great surgeon with us, and he's a very versatile surgeon, Mehul. He is able to, do CABG in very poor ventricle, even CABG with aneurysmectomy, CABG aneurysmectomy with valve replacement, all those stuff, because he has to work with us. He is not lucky enough to have great cases for CABG. And he is working and he is offering us great results, and more than 50% of them are total arterial. He doesn't touch the leg veins in many of them.
Tejas, what do you think about doing DK crush on here?
No. Yeah, it is a good thing, but I am confident of recrossing, and DK crush I hardly have any experience. Maybe a couple of cases we have done, so I will not do. Otherwise, yeah, that is also a good strategy.
Yeah, but it increases radiation, contrast, and time.
So Raju, again addressing your previous question, before if I used to see osteal left main or body of left main disease, we were calling the surgical consult before we intervene on that. Last 3 or 4 years, I would say we have changed the practice a little bit. We are all employed by the same hospital, so cardiothoracic surgeon and interventionists, we all work together. And we have every Wednesday heart team meeting where we discuss multivessel disease patient before deciding intervention versus cabbage.
Perfect.
Looks good?
Looks good.
Looks good.
I'm going there. stand.
12.
12.
Okay.
Fine.
Come down. We'll go up again. Go up again. 12. Come down.
We'll remove 2, all 2.
This is the one, right?
बस आप एक काटना
Chalo out. Okay. See, we are removing even the wire, not to worry. Fine.
So just as a follow-up to Kinta's comment there, so we've had a similar experience at Mayo Clinic.
Looks great, Sanjay.
Where I think we're doing a lot more left main interventions, particularly in emergency ACS situations. And I think it's fair to say that we started moving away from just assuming that cabbage is the default revascularization for left main. I think there's much more room for discussion now.
पाँचों लाइन आप वो तो पास है LMCA में ले लो LMCA में आपको yes okay यहाँ पे थे ये guiding bar ले लो fine
it's okay 20 come down
20
left main stenting balloon angioplasty was the concept initially floated by Jeffrey Hertzler. So Malcolm and Rajiv, he was a Mayo alumni, right? So we want to hear something about him. He is the one who opened up the avenue, different avenues for interventionalists. I feel I have never had an opportunity to meet him or talk to him. I was always looking forward, but I never got that opportunity.
So, Tejas, you're absolutely right. So, Jeff Hertzler was one of the interventional cardiologists at Mayo Clinic for many years before he moved to Kansas City. I did actually have the opportunity to meet him a couple of times. He was an incredibly nice person, a thorough gentleman, very humble. And unfortunately, he died a number of years ago, actually of as I recall, of a lymphoproliferative disorder. And one makes wonder whether that was from radiation. But I first saw him in Australia, and I thought it was like a cowboy came in and showed multiple slides. It was in a slide carousel, and he had about 3 slide carousels, and he showed us these amazing cases. A very skilled operator, as I said, a very humble person. He also actually did the very first PTCA at Mayo Clinic. Mm-hmm. So that was in, this is obviously many decades ago. It was a very pivotal moment in the history of Mayo Clinic in terms of coronary intervention. So I'm very sorry that you did not get the opportunity to meet him. There may be some members of the audience here who had met him.
Because John Bresnan in his talk always mentions at the first slide, if you have not done enough complications, you have not done enough. Geoffrey Hertzler.
You've either not done enough or you're lying.
I met him at one course. He's a really nice gentleman, very good skill. But I heard he also has a terrible spine disease. It's wonder from the lead he wear for the last 40 years, something like that. Is it true?
Yeah, it's true. And in fact, I've met one other very prominent, very famous interventional cardiologist who was at the he was one of the pioneers of PTCA in the United States, who could not wear lead anymore because every time he wore lead, his arm would become paralyzed. And so actually he had to stop working in the cath lab.
Hello, sir.
Yes. Good.
I'm Dr. Sabina Hashim, sir.
Yes. 2.5 stand.
I was asking, sir, is there any role of pot before recrossing the wear in the side branch? Any role of pot, sir, as it reduces the malactivation?
Yeah, if it is a provisional stenting, the distalmost strut should be crossed, which is near the carina.
Tazuna 2.5.
But if you are thinking of 2 stent, then it is okay if it crosses any strut.
Synergy? This emerge?
Yes.
Rajiv,
red balloon 2.5.
Emerge. Rajiv, I am using the same used balloon. You were telling me, I will show you. This will, to cross the strut. Hope I cross it. By and large, we do that.
We have dilated LED circuit both with this balloon.
This one, very
this is sir. No, sorry.
Tejas, could you remind us what type of stent you put in the LED left main there?
Everything is Zions.
Everything.
LED, surge,
So
everything is Zions.
You cross the surface, Dr. Patel?
I am just opening up, see, it is not going in. It is not going in. So I will just change the dimension of my guide to make it little straighter for it to go in.
See, there may be some wiring intertangle.
Wire bias?
No.
No, I need to take a new balloon.
First we confirm that wire are not crossed by
Yeah,
putting this balloon in LED.
So LED wire I will remove first.
No. We insert this balloon in LED. If it goes, then there is no.
Okay, fine.
Wire.
Sanjay says that you insert this balloon in LED. If it goes smoothly, there is no wire intermingling.
Sometimes I using the balloon in LED first, because if the SERP balloon not go down, I can using the balloon anchor, so you can get down the SERP.
But
do that.
That was a great tip, tack the balloon anchor technique in the other vessel. It used to be more of a problem crossing with the older stents. I remember with the thicker strut stents.
It has gone.
But no, it is going.
Yes, so that there is no wire problem. Okay.
So you are removing it.
And we take new
balloon. Yes, 2.5 Tazuna. 2. Tazuna will go. I think that is one of the most versatile balloon.
2 by 10. No, 2 no lie.
You don't have it in United States, huh? It's a great balloon.
As far as I know, I'm looking at my colleagues here. I don't think we have the Tazuna balloon in the US.
Yeah, give me. Show that technique for people who have not seen. I mean, sometimes you may have difficulty putting your wire in the balloon. This always works. Sanjay, show it again.
Yes, this is a nice technique.
This, he is using, the injection syringe. Yeah, 100% it works. For all those who have presbyopia,
So that's a wonderful tip, and as I'm getting older, I'm going to probably need to use that. My only challenge is I may not remember this trick.
Why?
Yeah, I still remember that Tejas sir went to our center, and I was assisting him. I was not getting my balloon wearing, so he taught me that trick.
Yeah.
You really like that?
Thank you.
Yeah, still remember. Thank you, sir.
Little back. We can tell it again. Okay.
I think Malcolm, Rajiv and all other international guests, we should write some book or atlas on just the technical aspects of angioplasty and what we have learned, for the younger generation. That can be of great help to them. Like our atlas of complications of coronary intervention, I am sure the young generation is going to sleep with it like they sleep with teddy bear, 100%. It's a
Tejas, the problem is that the younger generation are not going to read a book.
yeah, we are going to have
And
an
so
app
maybe
also.
it needs to be on YouTube.
Yeah, and we are going to have an app also. Yeah.
Picture. Okay. No, that is okay.
Okay. Yeah. Now
kissing.
Kissing. 2.5 in circ and maybe 3 in LED. Get me a 3 millimeter emerge or
2.5
emerge you already have. And then be ready with OCT. So we will finish this case in another 7 to 8 minutes, and Tak Kwan is going to show you some new tricks with multi-vessel before lunch. Yeah.
The new trick is a balloon stent.
And for the young cardiologists, after lunch also, we are going to have a great session. You can take the advantage of the experience of the international guests. We are going to have some great didactics, and in panel discussion, we are going to have some very interesting discussion. So, be ready for that.
Tejas, could you just remind the audience, well, maybe just remind me, the size stent that you have in the LED left main and the circ, and then what size balloons you're going to use for the kissing, and what your usual strategy is in terms of selecting your balloon size for kissing.
Yeah, 2.5 for circumflex and 3 for LED kissing in the left main. So total circumference will be 3.5 millimeter, 5.5. And Sanjay, you explain why we use that.
Yes, I think the proximal diameter should be the diameter of summation of two diameters of branch, and the 2/3 of that should not exceed 2/3 of that diameter. So if LED plus circumflex total diameter is 3.5 plus 2.5, so it's a 6 millimeter. So proximal dilatation should not be more than 4 millimeter, ideally.
Malcolm, what is your opinion on this statement?
I have to confess, I'm not usually so precise. It's a little bit of guesswork and what balloons I actually have out on the table.
Circle a little bit more. Little more. Okay.
That's fine. Okay. Go. Unfortunately, there is a balloon with one marker and the other one is with 2 markers. But we'll manage.
4, 6, 8. Cine.
Okay, come down.
Okay.
Looks good. Okay. So we remove the balloon and put the OCT in LED, right?
We take shoot like
this. Let's take it. Looks nice.
Nice.
Professor, are you okay? We will doing OCT.
So straight away karna ko. LED kai.
It's okay. I'll do it. No, don't worry. Give me wire. Yeah. Yeah. Fine. Give me LED wire.
Tejas, while we're getting ready to do the OCT, can I take the opportunity to ask Dr. Akasaka at the back there what he thinks the maximum diameter vessel can be for an OCT?
Super.
I mean, some of our left mains in the US are pretty big. What do you think is the maximum we can use for OCT?
I'm not sure the correct number, but maybe decent OCT can identify around 7 or 8
septal.
millimeter.
Epicranial.
The catheter position is very important in getting a good image in left main, in a big left main. But an Asian patient might be less than 5 millimeters. We can do the bifurcation treatment by OCT guide.
That's good information. And my second question, while I have you there, is the osteal disease. Can you get enough opacification?
I agree. Yes. Also, we need anyway the blood flush by contrast or 10% lactate dextrose. So just proximal region of left main or RCA OCT cannot work. So at that time we used IVAS. Yesterday I had the lecture showing our experience in my institution. We do the OCT guide nearly 70 to 80%, but still use an IVAS guide about 20% because of just proximal region and the CTO intervention. We prefer to use IVAS more than OCT. This is our daily clinical practice.
So while we have you there answering some of these questions, another question that comes up, and it's a concern that's expressed by some people that in a patient with chronic kidney disease, they're concerned about giving a lot of contrast. We use 20 cc injections typically in our lab. So I wonder if you could just tell us how you deal with that with your patients. Are there other agents that potentially could be injected, or are there other agents on the horizon that we could look forward to using?
It's a very important point. Anytime the IVAS ask us the total amount of contrast. When you dilate balloon after putting a stent, you try to check by the contrast injection. But in our institution, if there are no complaints and no ECG change, we try to get an image at the same time with angio. It may reduce the total amount of contrast. And if there are some concern about the kidney condition, we use 10% lactate dextrose.
Just tell me when to inject.
Okay, we will start the OCT.
He's just arranging for the manual.
Okay.
Inject and record.
Great.
Fluoro भी record कर लो. चलो CT नाकिल तैयार दाग लेते हैं.
It's good image.
We could get a good image.
Lot of calcium is seen.
Very wonderful position in the distal LAD. And some calcium you can identify.
Calcium waves, yes.
You also want to remove the lumen profile?
Pardon?
I try to remove the lumen profile.
Okay,
Yes. So it will make image bigger.
Okay. And then you can identify two strata, right? Overlap, right? Here.
Yes.
Now.
Here is in the CX.
LCX.
Okay, again, this is the just proximal
Guiding.
site.
This is
here is a little bit complex condition in the CX, right?
Yes.
Some strata here and yes. So sometimes difficult to understand just the cross-sectional view, right? So sometimes we use a longitudinal view and 3D reconstruction, what really happened in this condition, right here?
Yes.
Okay, we try the 3D reconstruction. All right. position difference stent and 3D bifurcation. Okay. So I would like to say some strut is here, right? Yeah. So maybe guide wire might be passed through the distal portion, but we cannot completely compress this strut to the the other side. Here is the CX, right?
Yes.
Yeah.
We're all being wowed by these 3D images here. It's like just incredible. One practical question, Dr. Akasaka, do you have to tell the machine what stent you put in, what brand, when it does its readout of the apposition, or it knows which stent is in there? Because you mentioned that the number of micron malapposition relevance is different from one stent to another.
I'm sorry, I missed the...
So when you're talking about malapposition and the number of microns,
yes,
you're saying for some stents there's one value that matters, for another stent it's a different value?
Right. Yeah, we do not have the data about the recent stent, but Giants less than 300 micron is okay. We don't dilate much more. It's depend on the condition, but it will disappear within a 6 month or 8 month follow-up. You can identify the very smooth coverage within the 300 micron incomplete apposition. But you have to pay attention to the proximal edge incomplete apposition. If there are some incomplete apposition during intervention, sometimes wire pass under the strut. So it is important to dilate the proximal portion. The apposition of the proximal portion is very important at the time of intervention.
Yeah. So another important thing which I wanted to highlight, is it was a 3.5 millimeter Giants in the left main again, and you see this is the Indian left main. Colonoscopy.
Yeah. So red color is the incomplete apposition. There's some portion, yes, here.
You want us to dilate it with a non-compliant 4 millimeter, that area, that is the junction, I think.
Yeah. It might be better to dilate. Yes.
We'll do that.
Yeah.
Okay. 4 by short quantum maverick. So, can we switch over to the last live demo case of the day, because we have many others to go, but we have lined up. But I think by that time there will be lunch time, and after lunch we are not showing any live. So Tak, Kwan and Rajni are there. So should we switch over to that lab?